Welcome to the judge's bench. I'm stepping in as your senior medical examiner today for an uncompromised, zero-filler explainer of the absolute life-or-death diagnostic tipping points in maternal-fetal medicine. We're cutting through the noise, and we are starting straight away with endothelial gestational crises. Let's get to work.
So picture this. A 36-week pregnant patient rolls in. Her blood pressure is 165/100, and she's complaining of right upper quadrant pain. Do you wait to act? Do you sit out it? Listen, in the delivery room, noise kills, and only the pure signal saves lives. Your brain has to immediately differentiate between overlapping pathologies to execute a plan. This brings us to a classic 50-50 dilemma that traps so many clinicians, distinguishing HELP syndrome from acute fatty liver of pregnancy, or AFLP. Both of them present with that right upper quadrant pain, elevated transaminases, and profound thrombocytopenia. So what's the actual tipping point? It's serum glucose and your coagulation pathways. You see, AFLP is a systemic mitochondrial defect. It presents with severe, life-threatening hypoglycemia. We're talking glucose under 50, along with a prolonged PT/INR. HELP, on the other hand, is a localized microangiopathic process. It typically preserves that serum glucose and maintains a normal coagulation profile, at least until it advances to DIC. So don't get distracted by borderline blood pressures. Look for that under 50 glucose signal. Now regarding blood pressure, 160/110 millimeters of mercury. This isn't just a number, it's a blaring siren. This absolute threshold indicates severe preeclampsia. It requires immediate pharmacological intervention, usually labetalol or hydralazine, to prevent a catastrophic maternal stroke, all while making sure you maintain vital fetal blood flow. You have to focus purely on that absolute signal. Severely elevated BPs and active multi-organ dysfunction definitively mandate two things: delivery and continuous IV magnesium sulfate for seizure prophylaxis. You know what the fatally dumb mistake is here? Delaying definitive delivery in a patient with documented AFLP or HELP just to give a prolonged course of systemic corticosteroids for fetal lung maturity. When maternal multi-organ dysfunction is actively compounding, you do not wait. Delivery is the only definitive cure. Moving right along to antepartum hemorrhage, a third trimester patient arrives with active, unevaluated vaginal bleeding. Do you perform a digital cervical examination? Your answer has to be instantaneous. We have to rapidly map out the placental shearing mechanics before we ever lay a finger on the patient.
Take a look at this stabilization matrix. This is your severity invasiveness scale. Your diagnostic tipping point here is uterine basal tone and pain architecture. You absolutely must differentiate the agonizing, unremitting abdominal pain and hypertonic, rigid uterus of a placental abruption from the completely painless, soft, non-tender uterus of a placenta previa. Abruption is driven by retroplacental hematoma expansion, right? While previa bleeding is purely driven by the lower uterine segment elongating over the cervical os.
So here's the golden rule. Never, and I mean literally never, perform a blind vaginal exam on unevaluated third trimester bleeding. You always establish placental geography via ultrasound first. If you blindly insert a finger and there's a placenta previa, you will disrupt those maternal vascular lakes and induce a catastrophic exsanguinating hemorrhage. Ultrasound first. Period.
Okay, let's shift gears to fetal cardiotachographic resuscitation. The monitor starts alarming with severe decelerations. Are you looking at umbilical cord compression, or is it uteroplacental insufficiency? To figure this out, we need to analyze the structural temporal alignment of the fetal heart rate with the maternal uterine contraction wave. Just look at the kinetic vectors on these tracings. The precise timing and the shape of that deceleration nadir dictate your entire resuscitation strategy. You aren't just staring at random dips on a monitor. You are analyzing the kinetic signature of fetal distress.
It breaks down like this. Late decelerations represent critical fetal hypoxia. They are defined by a delayed nadir relative to the contraction peak. That's your classic hallmark of uteroplacental insufficiency. Variable decelerations, on the other hand, drop abruptly and entirely independent of contraction timing. That is the mechanical hallmark of umbilical cord compression. You need to memorize these kinetic vectors. Variable decelerations plunge from onset to nadir in under 30 seconds. Late deceleration nadirs occur strictly after the uterine contraction peak. Recognizing the difference between a 30-second abrupt drop and a delayed nadir is, quite literally, the difference between calling an immediate crash cesarean and just doing a simple, rapid maternal repositioning. It's a huge deal.
Now let's dissect the RH isoimmunization trap. This is a classic scenario where clinical assumptions routinely lead to absolute disaster. You've got an Rh-negative mother at 28 weeks, and you see a sinusoidal fetal heart rate on the monitor. Do you just empirically administer Rogan prophylactically and move on?
First, you really have to understand what that monitor is screaming at you. A sinusoidal waveform is never a benign finding. It is the terrifying, distinct signal of severe fetal erythroblastosis, profound anemia, and active fetal exsanguination caused by Rh isoamminization. The maternal antibodies are actively destroying the fetal red blood cells in real time.
So, the fatal flaw here, and honestly a massive trigger for malpractice, is blindly giving RhoGAM to an unevaluated patient. You must check the baseline antibody screen first. If she is already alloimmunized and her baseline screen is positive with a high anti-D titer, giving RhoGAM provides zero therapeutic clearance. The drug is completely useless and the fetus is actively dying.
All right, let's step up to the bench for some mandatory validation drills. I want to test your reflex against the noise. Drill 1. A 36-year-old at 36 weeks presents with a BP of 165/100, right upper quadrant pain, and 3+ proteinuria. What is your precise execution order?
Here is your absolute threshold execution. You have to instantly recognize severe preeclampsia. You initiate labetalol or hydralazine for the blood pressure, you start continuous IV mag sulfate for seizure prophylaxis, and you execute immediate delivery. Do not, under any circumstances, get distracted or delay your action by agonizing over that right upper quadrant pain. The only cure for this compounding multi-organ cascade is delivery.
Okay, drill 2. A 20-year-old at 28 weeks gestation is brought in after a high-speed collision. She's showing altered mental status and confusion. You check the fetal heart rate and it's a reassuring 140. What is your priority? In this trauma vignette, clinicians get trapped all the time by staring at that reassuring fetal monitor instead of securing the primary life form.
The absolute threshold here demands an immediate CT scan of the head and neck. Maternal stabilization and ruling out an intracranial hemorrhage directly supersedes any immediate fetal interventions. I know there's a pregnancy, and I know there are concerns about radiation, but you must act on the maternal trauma. Why? Because a dead mother results in a dead fetus. You secure the airway, breathing, circulation, and central nervous system of the mother first, every single time.
And with that, court is adjourned. I want you to review these matrices and really internalize these absolute thresholds. The delivery room is an incredibly chaotic environment, packed with overlapping symptoms and panic. When that clinical alarm sounds in your unit, will you be paralyzed by the noise, or will you execute flawlessly on the absolute signal? Thanks for joining this explainer, and I'll see you next time.